Hi, everybody. Thank you for coming out today. I'm Dr. Frank Marrero. I'm the director of the Digestive Health Center here at Memorial Hospital. Um, Today, I've been asked to talk about colon health, and I wanted to focus it on colorectal cancer screening. March is Colorectal Cancer Awareness Month, and this is a very important topic, and I'm going to go into a lot of details on colorectal cancer, colon screening, and colon health. I'll be happy to take questions. I've been asked to have y'all hold the questions till the end, but if you have any questions, jot it down so you don't forget, and I'll be happy to go through any issues or questions that you may have. I want to give a little bit about my background. I'm from a very small town called Wills Point, Texas. Anybody ever heard of that place? No, very few. I had a patient the other day that used to drive a grocery truck through there, so he actually knew where it was. But most people don't. Most people have heard of Canton, which is right here where they have the big flea market once a month. But I spent 8 years in the Army Reserves. Went to college and medical school at the University of Massachusetts, and I did my internal medicine and my gastroenterology training at the Cleveland Clinic in Ohio. And I served as a chief medical resident and a chief fellow there. And for those of you that don't know, a gastroenterologist is a person that specializes in gastrointestinal health. Currently, I'm serving as the medical director of the Digestive Health Center. I've been here about 2.5 years. And again, just to remind everybody that March is Colorectal Cancer Awareness Month. And just to answer the question, what is colon cancer? It's a cancer that occurs in the colon or the rectum, and otherwise known as colorectal cancer. And here's a picture of a colon cancer. So why is colorectal cancer important? Well, it's a very common and lethal disease. There's around 150,000 new cases diagnosed in the United States every year, and around 50,000 people die from colon cancer every year. So this is a very important issue. And if you look, colon cancer is the second leading cancer killer in the United States. It's right behind lung cancer. About every 9 minutes, someone dies of colon cancer in the United States. And if you look at the mortality, colon cancer is right here, number 2, right behind lung cancer. Right behind it is breast cancer, prostate cancer, pancreatic cancer. So where does colon cancer come from? Under most circumstances, colon cancer starts as colon polyps. Colon polyps are just little small growths that eventually over time can turn into colorectal cancer. And this is in general, when we're doing a screening colonoscopy, what we're looking for, hopefully we find this and not a cancer, because these can be easily removed. Once they're removed, the risk of that polyp causing a cancer has ideally been eliminated. And we think it takes about 10 years for a small polyp to eventually grow into a cancer. And the definition of a cancer really is this abnormal tissue that grows into the wall of the colon. So while this one technically has a cancer in it, the old term for this used to be called carcinoma in situ, which is just means on the surface. So you can remove this through the endoscope, but once it kind of breaks the barrier into the colon wall, it is truly a cancer, an adenocarcinoma. And if it gets more invasive, it's a higher grade carcinoma and has a lot more risk to the patient. So how does Louisiana compare to the rest of the country as far as colorectal cancer incidence and screening? Well, if you look at the rates of colon cancer, and this is per 100,000 persons, Louisiana tends to be a little bit higher than the rest of the country as far as however many patients are diagnosed with colon cancer. It tends to be higher in a lot of areas: prostate cancer, lung cancer, colon cancer. It's a little bit less in urinary bladder cancers, but just about everything else, kidney, lymphomas, or non-Hodgkin's lymphomas, oral cancers tend to be a little bit higher. Leukemias, pancreas cancer, and other things tend to be around the same or a little bit less. But colon cancer compared to the rest of the United States, and we're pretty much at the top of the list. Alaska, Kentucky's ahead of us, but this is obviously a list we don't want to be at the top of. We want to be down here. So Utah is right at the bottom. And again, these are rates per 100,000 people. It's not that Utah has fewer people than Louisiana. This is compared, it's a very equal comparison. Now, as far as screening, the Centers for Disease Control looked at patients aged 50 to 75 who reported being up to date on colorectal cancer screening by state. And this is not screening colonoscopy. This is any method, even just doing the stool cards, which is considered not the best test for colorectal cancer screening. Louisiana tends to fall kind of in the middle of the road. There are some states, Texas, Oklahoma, Mississippi, Alabama, kind of around us that tend to have fewer persons screened. But there are a lot of states, particularly in the Northeast and in Washington, that have a much higher rate of screening. And it'd be nice to see us be up in the top echelon of screening, and hopefully that would reduce our rates of colon cancer. So a lot of patients ask, well, how can I prevent colon cancer? And one of the most important things to do is eat a healthy diet, lots of fresh fruits and vegetables. This has been shown to reduce colon cancer incidence. A poor diet, diets high in saturated fats and meats tend to increase risk for colon cancer. So we're all familiar with the boudin and cracklings. Probably one of the worst things you can eat to reduce your risk. But also importantly is to get screened, because not only is diet a large part of it, but also genetics is a part of it as well. So there are those of us that are at risk no matter what we do, and screening is the only way to help that. So a list of things to consider. So getting screened regularly, maintaining a healthy weight, and maintaining a physically active lifestyle is important. Consuming a healthy diet, and drinking in moderation. But something not on this list that's equally as important is to stop smoking. Smoking has been associated with colon cancer as well as lung cancer, and probably just about every bad thing that can happen to you as far as cardiovascular disease goes as well. So, who should get screened for colon cancer? The guidelines suggest that anyone the age of 50 or older should be screened. The reason for that is if you look at the population, the incidence of colon cancer starts increasing at around the age of 50. So that's when we decide to start screening people. However, if you have a family history of colon cancer, mother, father, brother, sister, you would generally want to start at age 40 or even earlier if that relative had cancer at an early age. And this is something that you would need to discuss with your doctor as to when the appropriate time to start screening would be. Anybody with a history of inflammatory bowel disease, no matter what age, is going to need to start colon cancer screening at more likely an earlier age, and that's because these patients are at higher risk for colon cancer as well. And inflammatory bowel disease would be something like Crohn's disease or, more importantly, ulcerative colitis. And then anyone with concerning symptoms, and I put this on here, if you have concerning symptoms, at that point you're not getting screened. You're getting a colonoscopy as considered a diagnostic test. And the big difference between screening by definition is taking a look at somebody that feels great, that has no symptoms. A diagnostic test would be doing a colonoscopy or some other test with the intent to find the cause of someone's symptoms. So that's an important distinction. If you have symptoms, you're no longer getting screened, you're getting a test really to see what the problem is. So what are the symptoms of colon cancer? A lot of times there are no symptoms. I diagnosed 2 colon cancers last week. Patients had no symptoms. They just came in for their screening. But some of the more common symptoms would be abdominal pain, a change in the bowel habit, which means really, if you have a bowel movement that occurs, once a day pretty regularly, then all of a sudden that changes. That's a change in the bowel habit. So that's something that you should discuss with your doctor. If you've had any obvious rectal bleeding or really dark colored stools, that's another reason to consider getting a colonoscopy or some other test. Just feeling weak, that could be a sign of anemia or chronic blood loss. And that would be another reason to get assessed. Just having anemia without any other symptoms or weight loss, specifically unintentional weight loss, as we're all aware of, it's very difficult to lose weight. So if you feel lucky, because all of a sudden the weight's coming off for no good reason, that's usually indicates that there's a problem and needs to be investigated. So there are a lot of different options for colorectal cancer screening. Colonoscopy is considered by most people to be the best screening test, but there are other options. There's a barium enema that can be done, a virtual colonoscopy, which is a type of CAT scan, and then there's fecal occult blood testing. So colonoscopy, I'm going to go into this in a lot more detail, and it's my preferred method for colon cancer screening. One reason is because that's what I do for a living, but also it's the only test that not only can look to see if there's a problem, but can also take care of the problem at the same time. A barium enema is a particular type of x-ray where they give you an enema of a material called barium. It shows up on x-ray. So they do the barium enema, they take multiple x-rays and see if there's any abnormality in the colon that would suggest a polyp or a colon cancer. And if that is positive, or if they find an abnormality on that test, then they're going to send the patient for a colonoscopy. The virtual colonoscopy is similar to the barium enema in concept. It's a CAT scan where you drink contrast, it fills the colon, and then they do a CAT scan to see if they can detect any abnormalities. And then again, if they find an abnormality, you get sent for a colonoscopy. Fecal occult blood testing, in and of itself, I feel is not an adequate test. It's much more, it's a better test to detect the presence of colon cancer, but not polyps unless they're large or advanced polyps. However, if that's the only thing you're going to do, it's better than nothing. Now, one of the advantages of colonoscopy over the other tests, barium enema and a virtual colonoscopy are both x-rays, so there's radiation exposure. Probably the most dreaded thing about having any kind of colon cancer screening is you've all heard of the bowel prep. You have to drink something that gives you diarrhea. And arguably, at least in my experience from talking to patients, that's the absolute worst part of this. You have to do a bowel prep no matter whether or not you do the barium enema or the colonoscopy. And then the fecal occult blood testing, again, it's really not the best test. But if you're only going to do one thing, it's better than nothing. So a colonoscopy, for those of you that don't know, is again, is the most effective screening test for the reasons that I stated previously. And it can reduce the average person's risk of dying from colon cancer by 90%. So, where can you get screened? Well, as far as colonoscopy, several types of doctors typically do this, more commonly gastroenterologists, but some surgeons do this and some primary care physicians, internal medicine doctors and family practice doctors will do this test. Barium enemas are done in the virtual colonoscopy are done in radiology or x-ray departments. So this would have to be ordered by another physician like your primary care doc. Fecal occult blood testing, again, can be ordered really by any physician. Now, as far as the colonoscopy procedure itself, one of the questions is what do you do before colonoscopy? And your doctor's going to give you specific instructions about what to do before the colonoscopy. They'll tell you what diet to follow. Everybody may do this a little bit differently, but typically you would be on what's called a clear liquid diet the day before the test. So if you were going to have your test yesterday when you woke up, you would only have broth or juice or things like that for the whole day. You may need to stop certain medications, especially things like aspirin or blood thinners, because if we find a polyp and need to cut it out, we want to reduce your risk of bleeding from that. Some people are more complex. They need to be on blood thinners because of serious medical problems, so that will need to be coordinated very carefully with the doctor before the test. And then your colon obviously needs to be cleaned out. We need to be able to see while we're in there, so your doctor's always going to give you some sort of preparation to take to clean out the colon. This list should be in your handout. It's not all-inclusive, but it has most of the common types of bowel preps. And I'm not going to go into this in great detail, but there are a lot of options for bowel preps. There's the standard Go Lightly. It's the 4-liter liquid preparation. And then there are various other things that are either in tablet form or smaller volume liquid forms. And depending on your medical history, you may or may not be eligible to take everything on this list. But again, that's a discussion that needs to be had with the doctor that's going to perform the test. So during a colonoscopy, in almost all situations, the patient would get some sort of sedation. I virtually sedate everybody. A colonoscopy can be done without sedation, but it can be uncomfortable. The tube going, especially around some of the curves and corners, can cause some discomfort in the patient, and most patients prefer to be asleep when they have it done. Now the scope, it's a thin tube, has a camera and a light on the end, and we put that into the anus and advance it all the way through the colon. And then we withdraw it and take a good look on the way, both in and out. And we look at the inside lining of the colon. We can't see anything outside of the colon, only inside the colon with this. And this is a diagram of the colon. These are some of the corners that I said, when the scope goes around some of these corners, it can cause some quite intense gas pain type cramping. And while we're in there, we may need to take biopsies. We may need to remove a polyp or some sort of growth. In almost every situation, we take photographs of certainly certain landmarks in the colon. One reason is to prove that we got all the way through the colon, and if we see anything abnormal, we want to document that as well. So what can be found in the colon? Well, some of the normal landmarks we look for would be to show that we've gotten to the end of the colon, or technically it's the beginning of the colon. It's where the appendix is and where the ileocecal valve is, and the ileocecal valve is where the small intestine empties into the colon. So that's technically the beginning part. So we take pictures of that to prove that we literally got a view of the entire colon. And we're looking for polyps, tumors, colitis or inflammation in the colon, diverticulosis. Sometimes we see hemorrhoids, and unfortunately sometimes we see stool in the colon. So some of the landmarks that we're looking for, again, to prove that we've gotten all the way to the very beginning part of the colon and seen everything, would be the ileocecal valve. So this is the valve where the small intestine dumps into the colon. And as you can see, this little kind of fat lip looking thing here is the valve. And then the other thing we look for is called the appendiceal orifice, which is the space where if you could go through there, you would actually be inside the appendix. And it's kind of a little half moon or crescent shaped indentation. So polyps are another thing that we look for. As you can see, here's an abnormal growth of tissue on the lining of the colon. And this is something, when we see this, we're going to want to remove it during the procedure. Tumors, something we look for. This is a cancer here. And also, this is a cancer. This is a tumor, but it's a benign tumor. It's called a lipoma. Lipoma is just a collection of fat tissue that grows right up under the surface of the lining of the colon. And this does not need to be removed. And there are certain ways we can identify that. We would almost always take biopsies of it just to make sure that it's not something other than a lipoma, but they're something very typical. So somebody that does a lot of colonoscopies would be able to recognize that versus something dangerous. Colitis. So this is intense inflammation of the colon. And looking at it, this could be a cancer. It's something that would not be able to be removed through the colonoscope, but we certainly would take biopsies or small samples of the tissue to look at under the microscope to confirm what it is. Diverticulosis is something that we commonly see. Diverticulosis are these little pockets you can see in the colon. How many of you have heard of diverticulitis? So diverticulitis would be if one of these pockets happen to get infected. Diverticulosis is really just a weakness in the colon wall. It just causes these little pouches to form. And typically, in and of themselves, they're harmless. They can cause people to have some symptoms, pain and cramping. They can bleed, and they can bleed significantly to the point where someone would need to be in the hospital, get blood transfusions, or even have surgery to remove that part of the colon. But they can, again, they can get infected as well. Hemorrhoids, another thing that we often see, and you can see this kind of lumped up bluish tissue. This is right on the inside of the anus. This is a very common, or one of the most common causes of just benign rectal bleeding. And then stool, and this is why we want patients to really follow the instructions on the bowel preparation. You know, this is a small amount of liquid stool that can easily be sucked out through the scope, and then we can see what's underneath it. But sometimes, you know, the whole colon is covered with stool, and this one has a lot of stool with debris and things in it that can't be sucked out. The port on the scope that sucks the stool out is very small, so any piece of fiber or something that gets in there clogs it up, and then we're really stuck. We can't do anything. And it also makes it where, you know, if could be a polyp underneath this stuff, we can't be sure. So it makes it where the examination is not ideal. So when we do see a polyp, you know, a lot of people ask, well, how do you get that thing out of there? For most moderate to large polyps, we typically put a wire around it and run electricity or cautery through it and literally burn it out. And I'll show you an example. So the first thing you have to do is identify the polyp. And this one's pretty obvious, a fairly large polyp there. And in a lot of circumstances, what I personally do is I have a small injector needle, and I'll put it under the base of the polyp, and I'll inject some salt water or saline under it. And what that does is it lifts up the polyp and makes it very identifiable compared to some of the other folds that are around it. It also makes it easier to get that wire around it to burn it out. And the third thing it does is it separates the polyp. Now, a benign polyp, by definition, is only on that superficial layer of the colon, and you can cut right through that without causing harm to a patient. Anything deeper than that, if you cut through it, it's going to cut a hole in the wall of the colon, and then that person's going to end up in the operating room and have to have surgery. It's a big production if that happens. So if you can lift that polyp up like this, you can safely cut around there, and it significantly reduces the risk of accidentally cutting a hole in the patient's colon. The second reason, if I inject saline under there and it does not lift up, to me that suggests that the polyp has grown into the wall of the colon, and it's more likely to be a cancer than just a benign polyp. In that case, I would only biopsy it, and then that person would go for that part of their colon to be removed in a non-emergency situation. And so here's a picture of the polyp with the little wire snare around it, and then here's after it's been burned out. You see a nice clean burn there, and the polyp's completely gone. You can actually see the polyp kind of laying down right there, and then we basically just, if the polyp's small enough, we can suck it through the scope. If it's a little bit bigger, we have to grab it with something and pull it out. We have little baskets and graspers and different tools to get it out. So if you choose to get a colonoscopy, you know, as I had mentioned previously, there are a lot of different types of doctors that can do colonoscopies, and there are all kinds of doctors that do colonoscopies do a fantastic job of doing them, but I'm going to make an argument for my own specialty as to why you should choose a gastroenterologist to do your colonoscopy. Now, as a gastroenterologist, we do 3 years of broad medical training after medical school. Then we do another 3 years that's really training specifically to take care of digestive diseases. And we spend a lot of that time doing lots of endoscopic procedures. And by the time we finish that 3 years, typically we've done well over 1,000 procedures that are supervised by an expert. And a lot of us, well, we've done a lot, and we've been trained to do this, and this is what we do for a living. And then once we're out in practice on our own, most gastroenterologists perform over 1,000 colonoscopies a year, and that's in addition to the other types of endoscopic procedures that we do. And there have been a lot of studies that show that gastroenterologists have better outcomes as far as fewer complications and better cancer detection and polyp detection. And many of you have heard of the practice of medicine. And medicine, it truly is a practice, just like playing the piano or playing the guitar or playing a sport. Some people have raw talent, but you also have to practice it. Practice means doing something repetitively over and over and over to maintain and improve your skills. And this is, obviously silly, but both people obviously can do a tattoo, right? Obviously one of the people are much more skilled than the other one. So this is why I would argue to go to somebody that practices quite a bit. And one of the main reasons is bad things can happen during a colonoscopy. Probably one of the most feared complications would be to have a perforation of the colon or a hole poked in your colon. Does anybody know somebody that's had that happen or had it personally happen to them? It's a big deal. It certainly is life-altering for patients and sometimes can be life-ending for patients. Bleeding is another risk. You remove polyps. It is a cut in the colon wall, and there is a risk that a blood vessel could be compromised and can cause bleeding. One of the risks also is missing something. The colon's a long, dark, hollow tube. There's lots of nooks and crannies. Sometimes the prep isn't great, and there's fecal material in there blocking part of the view. So it's always possible to miss a polyp in the colon, and we know that happens. Even the best endoscopists miss polyps. And having a complication of the anesthesia. Like I said, almost everybody gets medication to put them to sleep before or through the test. While the anesthesia we use is extremely safe, there are cases where someone would have an unexpected bad reaction to that medication. And this is a surgical picture of a perforation or a hole cut in the colon. And this is somewhere we obviously don't want to go. All right, this is a bad thing that could happen. So some important questions to ask your doctor, whether it's a gastroenterologist, a family physician, a surgeon, or whomever that's going to do your colonoscopy, is, do you miss polyps or cancers? Well, obviously, if you missed it, you didn't know you missed it. So we have some ways to look and do some internal quality control. There's a phenomenon or some data that we look at. It's called the adenoma detection rate. And what that is if we look at 10,000 people that had a screening colonoscopy, we can narrow that down and say, well, of all those 10,000 people, about 30% of the time, adenomas were found in that patient. So we know that when we do procedures, about 30% of the time, we should find adenomas. If we're finding less than that, we're not doing a good job. Now, this is something that anybody performing colonoscopies, in my opinion, should maintain. And actually, in the future, we're not going to get paid unless we can prove that we're doing a good job. But this is something you should feel comfortable asking your doctor. Well, what is your adenoma detection rate before they do your procedure? Now, something that's been really hot in the quality control literature in colonoscopy is how long does the doctor spend looking at the colon? You can go in and come out in 2 seconds, and you're not going to see anything. you can, and there's been some data that suggests that doctors that spend at least 6 minutes or longer tend to have better detection rates of polyps. There are some flaws in this because at some point they had made it almost a mandate that you had to spend 6 minutes, and it's easy to spend 6 minutes. You get to the end and it's been 5 minutes. You can just stand there for a minute. That doesn't do anybody any good. So really, the more important thing is, are they finding things in the colon rather than how long they're spending looking. You should always feel comfortable asking your doctor how many complications they've had. How many times have you accidentally perforated or poked a hole in someone's colon? How many people have had severe bleeding? How many people have had a complication of anesthesia? If your doctor is not able to or not willing to answer that question, you have other choices. There are other doctors to go to. Incomplete exams. A colonoscopy is not the easiest test in the world to do. It does take quite a bit of skill, and not every doctor can commonly get all the way through everybody's colon every time. And if you're going to go through the risk, the discomfort, the time off of work, the time out of your life to have a procedure done, you want to make sure that you get your procedure done and not get half your procedure done. So every doctor should know what their cecal intubation rate. As you recall, the cecum is the very beginning part of the colon where the small intestine empties into it. It's where we take pictures to prove we've been there, and we should get there greater than 95% of the time. And in a screening colonoscopy, in my opinion, it should be greater than 99% of the time. It should be very rare that we cannot get through the colon. And do they take the proper photographs and everything to prove that they got all the way through the colon? These are all things that you should be very comfortable asking the physician. And again, cecal intubation should have a photograph showing two things: appendiceal orifice, ileocecal valve, means they got all the way through. So some take-home points. Colorectal cancer screening, extremely important. I think colorectal cancer doesn't get the same press that breast cancer. You see the pink ribbons, people doing walks and runs. More people die of colon cancer. This affects men, women, everybody. So we need to get the word out. If you have friends, relatives that haven't been screened, they need to get screened. Colonoscopy, again, I'm going to argue is the best way to do it. It's a very safe method, and if done by the right person. People shouldn't fear having a colonoscopy. They can talk to their doctors if they have any concerns, and hopefully those can be alleviated. But if colonoscopy is not what you're going to do, there are other methods. Get something done to get screened. And if you choose to do colonoscopy, make sure you're getting the best quality study available. Choose your provider wisely. Ask that person a lot of questions. And obviously, I do colonoscopies, and I'd love to have your business, but there are plenty of excellent gastroenterologists, surgeons, primary care providers in town that do this test as well. And my general feeling is, while I'd love to do your procedure, if you want to get it, if you're going to get it done, if you need to get it done somewhere, somehow, just get it done. That's it. Thank you. Appreciate all of your